Our first speaker is Aaron Cohen, who is affiliated with the Health Effects Institute and has been a longtime leader in the field of global burden disease attributable to air pollution. Thank you, Aaron.
Well, thank you, Joshua, and good afternoon, everybody. I hope you're over your any postprandial drowsiness. If you're not, hope I don't put you to sleep. So I want to thank the organizers for inviting me to speak with you today about the global burden of disease from lower respiratory infections attributable to air pollution, or LRIs. Why LRIs? Are these the only infectious disease outcomes associated with air pollution? And the answer is, well, no, they're not. Household air pollution has been associated with tuberculosis, as has secondhand smoke, and tuberculosis, of course, is a leading cause of global mortality and morbidity. And ambient air pollution has been associated with case fatality from SARS and also adult respiratory distress syndrome, which in some cases has an infectious etiology. And finally, high levels of windblown dust, which is a sequela of climate change-driven desertification, have also been linked to epidemic bacterial meningitis in the Sahel region of Africa. But LRI is the #1 global cause of infectious disease mortality, responsible for 2.6 million deaths in 2017, and air pollution is a major factor. The estimates I just cited, and that I will discuss with you today, are the most recent estimates from GBD 2017, the most recent update of the Global Burden of Disease Project, which, as I think some of you know, is a large international collaboration of more than 3,000 scientists from over 100 countries, and it's led by the Institute for Health Metrics and Evaluation at the University of Washington and funded by the Bill and Melinda Gates Foundation. GBD 2017 quantified the magnitude of health loss in terms of disability-adjusted life years, or DALYs, or lost years of healthy life, and deaths from over 200 diseases and injuries in 195 countries from 1990 to 2017. And GBD 2017 also estimated the burden of disease attributable to 84 major health risk factors, including ambient and household air pollution from the burning of solid fuels for cooking. GBD 2017 updates any previous GBD estimates with new data, methods, and the estimates are now updated yearly. The major GBD 2017 results were published in The Lancet in November 2018, and I'll give some links at the end of the talk. People can go and get more information. But before discussing the burden of disease from LRI attributable to air pollution, I think it's important to consider the upstream forces that underlie the current burden and changes in that burden over time. Now, this slide shows the changes in life expectancy at birth from 1970 to 2017 for 21 global regions, with 2017 on the x-axis and 1970 on the y-axis. And in all global regions, life expectancy at birth has increased, reflecting an epidemiologic transition characterized by increasing mortality from chronic/non-communicable diseases and a marked decline in mortality from communicable diseases such as LRI and in mortality from maternal and neonatal diseases. And indeed, age-standardized rates of mortality from LRI have decreased worldwide since 1990 by 46%. And this decrease was driven largely by major declines in LRI mortality in children under 5 on the right, where rates fell by 67%. These changes were driven in large part by changes in multiple risk factor exposures, including increased vaccination, improved sanitation, and household air pollution. Age-standardized rates of LRI mortality, shown on this slide, from all LRI risk factors were more than halved from 1990 to 2017. But LRI remains a major global cause of death, and this slide shows the leading causes of global mortality in 2017. Heart disease, stroke, and COPD were the 3 leading causes, all related to air pollution, by the way, but LRI was the 4th, accounting for 2.56 million deaths. In GBD 2017, the burden of disease attributable to ambient and household PM2.5 was estimated for ischemic heart disease, stroke, lung cancer, chronic obstructive pulmonary disease, type 2 diabetes mellitus, and lower respiratory infections. And we also estimated the burden attributable to ozone exposure for COPD. This is a map of global age-standardized LRI mortality in 2017, and the rates of age-standardized LRI mortality varied by more than 30-fold across the globe, from about 5 per 100,000 in Austria to about 160 per 100,000 in the Central African Republic. So considerable spatial variation in LRI. And indeed, LRI is a major contributor to disparities in DALYs, or lost years of healthy life, when we classify countries according to a socio-demographic index, which is based on a combination of income, education, and fertility. And so LRI plays a major role, clearly, in low SDI countries. So what role does air pollution play in the global burden of LRI? Well, before I answer that question, I want to briefly describe how we estimate the burden of disease attributable to air pollution in the GBD. This is a schematic of the main steps that this estimation involves. First, we estimate exposure to ambient and household air pollution on a global scale. In GBD, we estimate population-weighted annual average concentrations of PM2.5 and tropospheric ozone, indicators of two relatively distinct air pollution mixtures for which there is now considerable evidence of a causal relationship with various causes of death. Next, based on the available worldwide health evidence, we develop a mathematical relationship or exposure response function that links exposure and cause-specific mortality for LRI and 5 major causes of death in terms of a relative risk per unit exposure. We use the estimated exposure and the relative risk to estimate the proportion of deaths in each country due to air pollution, so-called population attributable fraction, and we multiply that proportion times cause-specific mortality rates to estimate the burden of disease attributable to air pollution for each cause, and then we sum the cause-specific burdens. Global average exposure to PM2.5, and this shows those estimates, was estimated in 5-year intervals from 1990 to 2017 at a scale of about 11 by 11 kilometers at the equator, using estimates from satellites combined with a chemical transport model and surface measurements and other geographic data. For GBD 2017, the database of ground measurements of PM2.5 included 9,945 sites in 116 countries. This map shows the estimated levels, as I said, of the population-weighted PM2.5. For household air pollution, our estimates are based on the proportion of the population in each country that uses solid fuels for cooking, which is estimated from household survey data. We link these estimates to a global database of household PM2.5 measurements from over 60 studies. Now, in order to estimate the exposure-response relationships over the entire range of exposure to ambient and household PM2.5, we use a mathematical model called the Integrated Exposure Response Function, or IER. There are separate IERs for each of the 6 causes of death included in GBD 2017, and this is the IER for lower respiratory tract infection with PM2.5 on the x-axis and the relative risk on the y-axis. The IER combines estimates of the relative risks for ambient PM2.5 and mortality with mortality relative risks from other sources of PM2.5, active cigarette smoking, secondhand smoke, and household air pollution, to estimate the risk of mortality at the highest levels of ambient and household air pollution. This approach assumes that the risk of mortality is a function of inhaled dose of PM2.5 regardless of source. The LRI mortality relative risks for both children and adults are estimated from this single IER using 96 estimates from 36 studies of LRI incidence and mortality due to exposure to ambient air pollution, household air pollution, secondhand smoke, and active smoking. The IER is evaluated over a range of exposure from current levels of ambient or household PM2.5 to a cleaner counterfactual level of approximately 4 micrograms per cubic meter, which is called the theoretical minimum risk exposure level. The curves were fit using a Bayesian approach in order to quantify the uncertainty of the estimates, relative risk estimates, which is which is indicated by the shaded areas, and modifications to the modeling structure have stabilized the shape of the IER curves in successive updates of the GBD. The overall uncertainty in our burden estimates is a function of the uncertainty in the PM2.5 estimates that I showed you earlier, the IER, which I'm showing you now, and the uncertainty in the counterfactual level and the baseline rates. So, air pollution in 2017 ranked among the most important global risk factors for mortality. High blood pressure, tobacco smoking, and high fasting blood glucose were the top 3 global mortality risk factors. Ambient PM2.5 was the 8th, contributing to 2.9 million deaths, or 5.2% of global deaths, largely from heart disease and stroke. 432,000 attributable deaths, or 15%, were from LRI. PM2.5 from household burning of solid fuels was the 13th leading risk factor for mortality in 2017, contributing to 1.6 million deaths, or 2.9% of global mortality. 459,000 attributable deaths, or 29%, were from LRI. So all told, ambient and household PM2.5 contributed to an estimated 4.9 million deaths in 2017, 8.7% of all global deaths, making it the 5th leading risk factor for mortality following diet, high blood pressure, and tobacco. 890,000 deaths, or 18%, were from LRI. Now, although it's the number of deaths due to air pollution that often gets the most attention in the press, a critical and arguably more important question for epidemiology and public policy is whether people die earlier as a result of exposure to air pollution, and what is the effect of exposure on life expectancy. Oops, excuse me. Oh. Yes. Josh Apte at University of Texas and colleagues recently estimated the impact of exposure to ambient PM2.5 on life expectancy at birth for 185 countries using the GBD cause and age-specific mortality data. And in 2016, PM2.5 exposure reduced average global life expectancy by about a year, with reductions of 1.2 to 1.9 years in highly polluted countries in Asia and Africa. In China, life expectancy at birth was reduced by an estimated 1.3 years. In 2016, LRI was responsible for a significant share of lost life expectancy, approximately 20% on a global scale, and 50 to 60% in sub-Saharan Africa. Now, this slide ranks the 10 major LRI risk factors in terms of their contribution to age-standardized LRI mortality in 2017 in selected countries and global regions. PM2.5 from ambient and household exposure was the leading global LRI risk factor and the leading risk factor in high, middle, and low-income countries. Global age-standardized rates were 12.4 deaths per 100,000, but there was considerable variation in age-standardized LRI death rates across the globe related to level of economic development. 0.99 deaths per 100,000 in the US, for example, versus 45 deaths per 100,000 in sub-Saharan Africa, and among middle-income countries as well, with 6-fold higher rates in India than in China. Well, what about trends in LRI mortality from exposure to PM2.5? Age-standardized PM attributable LRI global death rates and numbers of deaths have declined since 1990 for both ambient and household exposure. The age-standardized rate declined by about 57% over that period. But trends differ between young children and the elderly by source of exposure. Decline in LRI mortality rates in children under 5 drive this trend, with 70% declines. And this decline was greatest for household exposure, which rates declined by 75%. But nonetheless, even these lower rates translated into a huge loss of healthy life, 32 million disability-adjusted life years in children under 5 in 2017. Among adults greater than 70 years, rates declined by 31%, due entirely to a 51% drop in mortality from exposure to household air pollution. But rates from ambient exposure actually increased in the elderly by 14%, and numbers of deaths by 143% in 2017. Recent mortality projections from the GBD project estimate that LRI will remain an important cause of premature mortality for the next few decades. But a recent study by Health Effects Institute estimated the burden of disease in India from major sources of ambient PM2.5 in 2015. And under a range of future scenarios of emissions reductions from major sources of ambient 2.5 out to 2050. With increasingly aggressive reductions, rates of lost years of healthy life declined in both urban and rural areas for cardiovascular and respiratory disease, including LRI, shown in blue, where the LRI mortality rate was nearly halved in a scenario that included the elimination of household burning of solid fuels. So the message here is that if we do something to reduce exposure to PM2.5 from major sources, we can expect to see reductions in disease rates for all the important causes of death, but for LRI specifically and quite clearly. So to summarize, mortality from LRI has declined since 1990. And especially in young children, but it still remains a leading cause of death in 2017. PM2.5 air pollution is the leading global risk factor for LRI mortality, and that's largely due to its effects in young children and in the elderly greater than 70 years, and the highest rates of LRI mortality from PM2.5 exposure are in low and middle income countries in Asia and sub-Saharan Africa. LRI from ambient and household exposures to PM2.5 have declined, but a considerable burden of disease still remains and will remain a leading cause of death in the future. And this is will entail a larger contribution from ambient PM2.5 exposure in older adults. Reductions in the burden will require concerted policy action, both to reduce exposure to PM2.5 air pollution from major sources, but also reducing other major LRI risk factors to maintain the declines that have been seen over the last 20 some odd years. So with regard to estimating future burdens of infectious disease related to air pollution, there are a number of research questions that occurred to me. I'm sure there are others, and others will have more suggestions. First, as I said when I was talking about the exposure response function, we use a single exposure response function to estimate the relative risk of mortality from LRI for both adults and children, and that's problematic. We understand it's problematic. It doesn't really reflect the epidemiology of respiratory disease infections. And it is at the top of our to-do list for the next update of GBD to develop separate exposure response functions for that. I think another question of importance is, does exposure to PM2.5 cause increased TB mortality? Why is that important? Well, TB was, I don't know if you remember from the slide, it's the 13th leading cause of death in 2017. It's about 1.2 million deaths from TB. And I didn't discuss the literature, which is, I guess, what people call suggestive. There is there is a literature which identifies a clear relationship between TB and active smoking, and a literature that provides, I think, fairly good evidence and has for a while for secondhand exposure to secondhand smoke. The evidence for household air pollution is weaker, and the evidence for ambient air pollution is non-existent, virtually. I think there's more than enough reason to think that air pollution affects TB based on all of that. And I think it should be a priority both to do studies of exposure, and we can, if people are interested, there's some specific characteristics of those studies that that are important, including the ability to differentiate between exposure to household air pollution and exposure to ambient air pollution. They're obviously highly correlated in the places where those exposures are both exposures are very high. It makes it very hard to separate out an estimate for example, for ambient air pollution. But epidemiologists are inventive, and I think we figure it out. The potential, if we do figure it out, and if the evidence supports a causal relationship, I think the impact on the burden, the air pollution related burden of infectious disease would be pretty substantial. Another question of importance, I think, is what are the effects of exposure to PM2.5 and other major LRI risk factors, and are these effects additive? Or are there joint effects or interactive effects? This is important to understand, I think, because it speaks to the design of interventions designed to lower LRI, and how targeted interventions across multiple risk factors could be implemented, and which ones should be focused on. And finally, which sources of PM2.5 are most responsible for LRI attributable PM2.5 attributable burden? Because after all, it is by controlling sources of air pollution that we reduce the burden of disease. So the studies that HEI is doing on burden of disease from major air pollution sources is a beginning to try to understand that, but that's an important research need going forward as countries like China and India implement air management, air quality management programs. Anyway, thank you very much. And I don't know if there's time for questions.